How do you apply pharmacokinetic principles, ADME, clinically in pharmacology? Imagine trying to give the right amount of medicine to someone, but their body processes it differently than expected. That's where understanding pharmacokinetics, or how drugs move through the body, becomes essential. The four key parts of pharmacokinetics are absorption, distribution, metabolism, and excretion. These help doctors decide how much medicine to give, how often, and through which route. Let's start with absorption. This is how a drug gets from the site of administration into the bloodstream. For example, if you take a pill, it has to pass through the stomach and intestines. Factors like the drug's chemical makeup, whether it's a tablet or liquid, and if you've eaten recently can change how much of the drug enters your blood. Some drugs, when taken by mouth, go through the liver first, which can break down part of the drug before it reaches the rest of the body. That's called first-pass metabolism. If a drug is given intravenously, directly into the vein, it skips absorption barriers and enters the blood fully. Clinicians watch out for things like antacids that can raise stomach pH and reduce absorption of certain medications. Next is distribution, which is how the drug travels through the blood to reach tissues and organs. Blood flow plays a big role here. If a drug binds tightly to plasma proteins like albumin, less free drug is available to act on the body. For example, drugs that are highly bound to proteins may need a higher dose to be effective. The volume of distribution, a number that shows how widely a drug spreads, helps determine the right initial dose, especially for drugs with narrow safety margins. If someone has swelling or low albumin levels, the distribution can change, so doses might need adjusting. Now let's look at metabolism. This is how the body chemically changes the drug, mostly in the liver. The liver uses enzymes, especially a group called cytochrome P450, to modify drugs. Some drugs need to be activated by metabolism before they work, like certain prodrugs. Others are broken down into inactive forms. Knowing how a drug is metabolized helps predict interactions. For example, if a patient is taking other medications that affect liver enzymes, it can speed up or slow down drug clearance. Liver problems can also reduce metabolism, leading to higher drug levels and potential toxicity. Finally, excretion is how the body gets rid of drugs and their metabolites. The kidneys are the main route for most drugs. If a patient has kidney problems, drugs that are cleared through the kidneys can accumulate, causing harm. Doctors check kidney function by measuring creatinine clearance or estimated glomerular filtration rate. For drugs eliminated through the liver and bile, liver function tests are important. Adjusting doses based on how well the organs work helps keep drug levels safe and effective. Applying these principles in real life means tailoring drug therapy to each patient. For example, if a patient has liver or kidney issues, doses are adjusted accordingly. Monitoring drug levels, especially for drugs with narrow therapeutic windows, ensures they stay within safe limits. Recognizing how drugs are absorbed, distributed, metabolized, and excreted guides decisions on how to give medications, whether orally, intravenously, or through other routes. It also helps predict interactions, side effects, and how different patients might respond. In medical school and during clinical practice, understanding ADME is like having a map for safe and effective drug use. It helps you choose the right medication, dose it properly, and monitor its effects. This knowledge is the foundation for making sure patients get the best care possible while minimizing risks.